What's that? All right. Greetings, everyone. We want to welcome you to Knowledge for Life's Raw Info Conference. This conference is on the Affordable Health Care Act, the good, the bad, and the unknown. As we know, the Affordable Health Care Act is implemented by the Obama administration, and it is meant to give insurance to the 48 million who are uninsured. There are aspects of it that we want to cover that particularly impact the Black community, because as we know, or as you will find out, there are things about the Health Care Act that we still need to understand, and those are issues that we will address today. Before we begin, we want to begin in prayer, and if we could, I want to say a Christian prayer out of the Bible, the Lord's Prayer, and then we will say a Muslim prayer, and then we will go ahead and open up. So if we could just take a moment. This is the Christian prayer out of the Bible, and it's the Lord's Prayer. And so we have it here, verse. It says, "Our Father, who art in heaven, hallowed be thy name. Your kingdom come, your will be done on earth as it is in heaven. Give us this day our daily bread, and forgive us our trespasses, as we forgive those who trespass against us. And lead us not into temptation, but deliver us from evil." Amen. And from the Holy Quran, it reads, "In the name of Allah, the Beneficent, the Merciful. I, Allah," excuse me. "In the name of Allah, the Beneficent, the Merciful, praise be to Allah, the Lord of the worlds, the Beneficent, the Merciful, Master of this day of judgment. Thee alone do we serve, and Thee alone do we beseech for help. Guide us on the right path, the path of those upon whom Thou hast bestowed Thy favors, and not upon those whom Thy wrath is brought down, nor those who go astray." Amen. Beautiful. First, I want to first thank the Wesley Center and Mr. Harris Tay for allowing us to be here to conduct this important conference on the Affordable Health Care Act, what many know in the streets as Obamacare. But of course, we know that, usually it was the right wing who liked to tag that name onto it, the Obamacare. But we know it in its proper terms as the Affordable Health Care Act. I want to go ahead and introduce our speakers for today. And I will start with our beautiful sister. And I want to just say that all of these individuals who are on the panel before I came in. The Emeritus Professor of Law at the University of Dayton since 1990. Randall writes extensively on and speaks internationally about race, on women's issues, and on health care. She is the recipient of Minority Health Chairman's Award, was named one of the top 10 most influential African Americans on the 2001 Black equal opportunity employment journalist. She's the professor, and she holds a BS degree and an MS degree in nursing. She's the author of a book that I have, a powerful book called Dying While Black. And her website, if you want to visit, is racism.org. And I believe that you designed the website as well.
And it's been on the web since 1995.
And it's been on the web since 1995. And you know that you have to be a web designer because the domain name, racism.org, that's perfect. You know, how can you get any better than that? And I want to mention what you will let us know more about is Racial Justice Now, which is to stop the preschool to prison pipeline. So we are thankful to have Sister VERNELLIA Randall with us. Our next person that I want to introduce is Sister CHERYL Scroggins from the Dayton Office of Minority Health. Sister CHERYL is the coordinator at the Dayton Council on Health Equity Public Health, Dayton and Montgomery County. She works with Asian Community Coalition, the Native American Coalition, and a host of African American groups here in Dayton. Public health recognizes the barriers to culture that these minority groups face. They provide health service in various languages. It's a gateway service for immigrants and refugees coming into the community, and initial health assessments. Some of the goals and objectives of the Dayton Council on Health Equity are monitoring and reporting health stats on minorities, to inform, educate, and to empower the minority community, to mobilize community partners to action, to identify and solve problems, and to examine and or develop level policies that eliminate health disparities. And you can go to that website at phdmc.org/DCHE. And last but not least, because we have to do the brothers last, you know, and we want to say that today is today Mother's Day? Tomorrow. So you see how much I keep up with the holidays of the Europeans. Because every day, the Honorable Louis Farrakhan teaches us that every day is Mother's Day. There's not one day that is not a Mother's Day. But since it is officially Mother's Day in America tomorrow, we want to wish our sisters happy Mother's Day. And so as brothers, I want to get my brother here, Brother Joseph J. Smith. He is the team lead sales and marketing at CareSource, Chief Master Sergeant, United States Air Force retired. He promotes enrollment to consumers and educates current health plan members and community at large. He coordinates activities with regional community and social service agencies, and his past experiences are the Director of Maintenance Facilities for the United States Air Force from 2006 to 2010, the Director of Human Resources for United States Air Force from 1998 to 2006, the Agent Registered Representative for Nationwide Insurance from 1999 to 2001, and the Marketing Rep for Healthcare HMO from 1995 to 1999, and the Marketing Rep for Health Power HMO from 1994 to 1995. So as we can see, we have stacked on the panel individuals who definitely know what they're talking about. Before we begin, I wanted to just read a passage out of this powerful book called The Torchlight for America. And as you can see, I've read this book quite a lot. And I believe that they're going to have a updated version coming out, hopefully, because if they don't, I may have to seal this one in some plastic before it totally disintegrates. But this is powerful because in this Torchlight for America, the Honorable Louis Farrakhan has a chapter, and this was written back in, let me get the date here, 1993. The chapter number 7, Ending the Healthcare Crisis. And it says, at about $750 billion in spending, America spends more on healthcare than any other country. However, very little of this money is spent on preventative care. If America seriously hopes to end its crisis in healthcare, it must redirect attention to preventative care. While I support a reasonable universal health care coverage plan, making America healthy must become the personal responsibility of each citizen, and not the responsibility of government, except in the case which will require that each individual become more knowledgeable, and that the leadership in the food industry, medical community, and government become more responsible in providing truth about caring for the human body. Lastly, it is sad buying material possessions is valued more than getting a simple yearly checkup by a competent doctor. It is sad that watching television several hours a day precedent over scheduling a few minutes of exercise that would help keep our bodies and our minds fit. It is sad that books, and it's a tragedy that we overeat, eat the wrong foods, smoke, take drugs, drink alcohol, and take an extensive amount of pills to cope with life's stresses instead of developing core values of self-control to protect ourselves. Addictions. Here again, the airwaves can be used to promote a healthy lifestyle among the people. And I will just end with that by saying that this is what Knowledge for Life is for. Our desire is to bring relevant news and information to our community via multimedia. And so we are not only taping this, but we are airing it now to inform and to get our people knowledgeable about the ins and outs of the Affordable Health Care Act. So with that being said, I want to introduce first our brother, Mr. Joseph Smith from CareSource, and he will give us the information about the Affordable Health Care Act and how we can maximize how to use the Affordable Health Care Act as far as signing up and things like that. So, Mr. Joseph Smith, you have the floor. Thank you.
Good morning, everyone. And again, I want to wish all the mothers out there happy early Mother's Day. So we should celebrate every day. And I miss my mom. My mom died several years ago. Great lady. So, like I said, do something special for yourself, and your family should do something special for you to recognize. So as we talk about the Affordable Care Act, we know that this past year was really the rolling out of it. It's been a program, planning stage has been for several years. It was really pretty interesting. I know at the beginning there we had some glitches, reference to the website things, but as of today, you know that roughly over 8 million Americans have signed up for the Affordable Care Act. And we know that roughly, last report that we got, that roughly 8% of them are paying their premiums for the Affordable Care Act. And really what the basis of the Affordable Care Act was to be able to give citizens the opportunity to have access to health care. Because we have a lot of people in the community that are working 2, 3 jobs, working part-time, but because they were not full-time, they were not able to get benefits. And I always ask people this one question: what does health care really represent? What does health insurance really represent? And I really sum it up this way: health insurance really represents peace of mind. It's safety and security. So with the Affordable Care Act, it gave folks the access to be able to get health care at an affordable rate. And so the folks that were out there working would have the opportunity to choose a health care plan, to choose different levels, to have access to health care that they didn't have. But let's face it, we do not spend enough on preventive care.
Right.
And we know that our community as a whole, unfortunately, a lot of folks thought that their family doctor lived in the emergency room. And we would not seek medical help until we actually had a crisis, until we had to go to the emergency room, which is not the proper way to access health care. We clearly understand that you need to have a primary care doctor to go in every year and to get a checkup, to get a physical, and be able to look after yourself. And it's really important for the breadwinners of the family. A lot of folks that you may have, maybe single parents or single fathers out there, mothers, that are out there working, trying to do the right things, trying to support their family. But a lot of times they would take the path of trying to self-medicate, try to go to the local pharmacy, maybe get something to release a pain or something to take care of a cold, when they really have a serious underlying problem. So one of the big pushes with the Affordable Care Act was to have people have access, be able to get them in that preventive care mode, which is going to take really education from the community. But the program was really, I think it has passed with initially wanted to try to attempt, but I think we're on the right road there. Now we know we just closed out the end of the period here, right at the end of March here, we're closed out, and then right now we're kind of in another phase right now with the expansion of Medicaid. Mm-hmm. Now the expansion of Medicaid, what that basically is calling on is that folks who meet the income guidelines, who are 138% of the federal poverty level. So a lot of folks may not understand that, but basically, if your income is below roughly $16,000 a year, that you now may be eligible for Ohio Medicaid. Mm-hmm. So that may cover before folks may not have been eligible for Ohio Medicaid because they were single males or single females, or if they weren't disabled, they did not qualify for Preventative. Those were kind of some of the barriers that are there. Mm-hmm. That has all been removed now. So basically now it's income guidelines. And there's a couple of ways they can actually apply. In that sense, since we're kind of in that mode there. Which is on Emeritus Most Boulevard. And they actually have a special room in there just set up for medical, room 281. And that's on the mall side of the job center over where the cafeteria is at. And they have access to be able to go into that room. They're only open Monday through Friday during normal business hours. If they're website savvy, they can even go on the web. And I will give you that website online. And the website that they would go to is, excuse me real quick as I look through my notes here, is www.benefits.ohio.gov. And they can go on there 24 hours a day and apply. And what happens is the county looks, they go in and look at the system there, look at your eligibility. If they deem you eligible, then you have the opportunity to get access to even Ohio Medicaid. Excellent. Okay. And I will go ahead and I won't take up all the time. I'll go ahead and pass it to my esteemed colleagues to my right here, and we'll get field questions later on and get into more detail.
All right.
Did you want
if you could go next. Yes.
Okay. Well, first of all, I appreciate being able to participate. Talk about the Affordable Care Act and the impact of the Affordable Care Act on our community. And I kind of wanted to come from a different perspective today. Because I think very often our history is lost because we don't have those conversations as we should. I think we need to understand the historical perspective of the Affordable Care Act because it has been a long time coming. Access is a very important aspect of health, of quality of life. And many people have been denied access to health care for some time because of socioeconomics. we live in a country of millions and billions of dollars, and it's just difficult to wrap your mind around the fact that there are people who live in our country who simply can't afford health care. And so to be able to go to a system that enables people to enroll and seek health care at a level that's affordable to them. And there are people who are not eligible for this particular system, but the majority of people are. So I kind of want to come from a historical perspective to remind the Black community of all the work that's gone before that has caused this particular act to be able to be in place today. And so I'm talking about moving the needle to improve minority health by providing access to health care. So I want to make sure that we're aware of our past. African Americans, we are from the continent of Africa, and our past is very, very rich in tradition, health tradition. We have been able to care for ourselves from our past experience. We are people who have a history of traditional health, and having been brought to this country against our will and been enslaved, we lost our freedom, and we became entrenched in a system that did not provide care. And as a result of that, Black people have suffered the reaction to that, whether it's been racial stress that has caused us to just historically have a significantly higher rates of many, many diseases. We have had to bear the brunt of not having health care across many years. But because we are a very intelligent people, a very determined people, we have had people that have come before us who have ensured that we have come out of and not only overcome but surpassed our condition. And so we want to give credit. We want to look back and give credit to all those who came before, on whose shoulders President Obama and the Affordable Care Act stand. People like W.E. Du Bois. W.E. Du Bois is one of our historians. He did some very significant work that we'll talk about in a minute. I have a slide up here in the middle of some Black midwives practicing the art of health long before there were hospitals, long before there was a system that would even allow Blacks to come and receive health care. Then I have a picture here of Dr. Martin Luther King, who with other civil rights leaders, did tremendous amounts of work to ensure that laws were put in place and that leadership of our country was aware, that we were aware that we were not being treated appropriately by the healthcare system. Finally, President Obama and Catherine Sebelius is here and working out the tenets of the Affordable Care Act, which are not perfect, but we are a long way from where we were. And so, I do want to make sure that Black people in our community are aware that there are some significant periods in our health from having been brought over as an enslaved people to today. We have come a mighty, mighty long way. And it wasn't by happenstance. It was by very deliberate action by a lot of people who I'm very proud to say came before. When we talk about Black health and we look at the different periods, we do have to accept the fact that in our history we were provided little to no health care. There was no treatment for the Africans who came over. As a result of just a need, we had a host of medical colleges that came into being. Meharry and Howard University are two that we are very familiar with those names, but there were about 7 colleges of learning for Blacks who were trying to provide the care that was needed to African Americans who were suffering at tremendously disproportionate numbers from the majority population. And so in 1906, W.E. Du Bois did a really significant paper. He published the it was called the health and physique of the Negro American, because the train of thought at that time in America was that Africans were genetically inferior, and they weren't, they just weren't to be afforded health care. They just were not considered to be, someone to be treated appropriately. And so, as a result of people like W.E. Du Bois and many others, a series of papers were written. That became a conversation. That became a conference. That became a movement that led to legislation and things like Title VII. There was a national Negro health movement right around the mid-1900s. They had a health week. Now, you are all familiar with Minority Health Month.
Right.
But its tradition is it came out from 1915 to 1935. They had that, and it was held in April, a week in April, because that was the month that W.E. Du Bois was born. And so even Minority Health Month historically came out of National Health Movement Week. Health Week. So we go back a long way, and I like having this history as part of the work that I do,
right,
because it's important to me that I remember all the work that's come before that has enabled there to be a local office of heart health. So we had several periods important. We skipped way ahead. The civil rights period enabled us to really have a lot of civil rights action. And so civil rights was a very important part of getting health care, because the civil rights activists made sure that our issues were heard, and made sure that the political powers that were in place at that time knew that we were aware of our condition, and they ushered forth some work that came after, particularly the Title VII civil rights legislation that brought about Medicaid and Medicare. So Medicaid and Medicare came out of the civil rights movement, and so we need to not forget that that was very important action. Dr. King then was one of our highly talented civil rights leaders. He did a lot of work in a lot of areas, and health was one of those areas, particularly some lawsuits that he brought against hospitals in particular, who provided very disproportionate care, and they had separate but equal care in the hospitals, and many hospitals wouldn't allow treatment at all. But we really had a long way to go still. And so when I think about the Affordable Care Act and the provisions that are in place now,
right,
that enable all Americans to apply for and receive health coverage, I can't help but think back over all this work that's come before, and I'm sure that they would be very proud indeed to see that this has been accomplished. Unfortunately, after the civil rights era, there was a post-civil rights era. There was a Jim Crow era. We lost some ground. There was like an very entrenched discrimination, period of discrimination and racism. And so racism and discrimination play a very, very important part in health, because minorities, not just blacks, but minorities in particular, continue to experience discrimination and racism in healthcare, and that is born out of just a lack of good health race relations. So this is something that really has to continue to be a part of our platform as minorities, to continue to ensure that race and racism remain on the front of the scope. Another piece of legislation that came forward for a report actually by Margaret Heckler, who was the then director of the United States Public Health Services. She provided a report to Congress right around 1983-85 that actually showed the disparities that existed between the races in terms of health. And that report said that minorities were experiencing significantly higher rates of sickness and disease. And as a result of that report, then an Office of Negro Health was opened at the United States Department of Public Health Services, and that was in place a very long time. And in that administration, a number of things were done to try and help minorities recover their health. And so one of those was the need for more research around minority health. And so a number of things happened after Margaret Hepler's report that continue to be delved into today. The United States Department of Health and Human Services, indeed, has created a national plan for action to end health disparities, and they too have published reports, and those are available at my office. If anyone would care to have that information, I'm certainly able to make that available to you. And so a signature event happened in 2000 when President Bill Clinton signed the Minority Health and Health Disparities Research and Education Act of 2000. And so we continue to have legislation coming forward, and all of it ushered forth from many of the efforts from W.E.B. Du Bois to today. And I think, to me, it was important to bring that to our community's attention, because we don't seem to really continue to have those conversations about our history and how the actions of those who come before have enabled us to stand today and have a higher quality of life. And we're still struggling in the arena of health disparities, because the health data still shows that minorities are experiencing significantly higher rates of some chronic illnesses and some social conditions. I think one of the things that prevents us from being able to make great strides in that is that there are not enough of us participating high enough in government that we have a voice, that we have the influence we need to cause things to really develop and incremental at a rate that really causes us to recover our health. And I think, too, a lot of times our community has been discouraged from being very vocal about and being direct about recovering their health. And it takes social cohesion to do that.
Mm-hmm.
So when we talk about social cohesion, we're really talking about some of the social determinants of health that impact people at the root. So we want to continue to encourage our community to understand that the Affordable Care Act is the result of many, many years of civil rights, social justice, and a lot of hard work. Mm. Now, the Affordable Care Act actually was approved in June of 2012. The Supreme Court upheld that, and it changed a lot of things. Particularly, it changed the model, the way that healthcare delivered, particularly how the health insurance companies are paid, and how the doctors and providers deliver the service. Instead of being like fee for services, in other words, doctors, they actually do, now the system requires that the doctors are paid based on the health outcome of the patient, which is a better model. Mm-hmm. And they are also not just incentivized to just do a number of services, but they're actually incentivized to provide the service in a way that causes the person to become well. As Joseph Smith said before, there were about 48 million non-elderly Americans who were eligible for health care, who were uninsured. Many of those people were people of color, not just African Americans, but Latinos, Asian Americans, and many others. And the majority of the uninsured were low-income families, and the majority were adults. And the Medicaid system had already put in place a number of things whereby women, particularly those with children, could be enrolled on Medicaid. But there are a number of families who are working, who had low income, who were just uninsured, they couldn't afford it, whose employers may or may not have provided insurance, or the insurance that was provided they couldn't afford to pay the premium. And so they just went without, or they just suffered. And it's very difficult to live in a country without insurance. I mean, just think about, I'm fortunate. I've been with the same employer 30 years. Mm-hmm. I've had health insurance. But I have people in my family who not had health insurance. And it's a difficult thing to be a wife or a husband or a mother and a father with children and not have health insurance because you can't afford to get sick. Mm-hmm. You can't afford to take a day off from work. And it's very difficult to maintain your health with that type of stress. And so we're very fortunate that people of low income, people of no income, people of low income, people who are employed but could not afford the insurance before can now apply for and receive this affordable care. In 2015, going forward, employers with over 100 employees will be required to provide insurance to eligible employees or pay a penalty. And subsidies are available for those small employers. And one of the things we don't talk about a lot is the penalty that people will pay who did not register, who should have. But this system did require people to sign on. And if you did sign on, there is a penalty that individuals will pay. And it's been approximated, Joseph, correct me if I'm wrong, right around $95 for like an individual.
Yes, ma'am.
But that would be per individual in the family. So if it's a husband and a wife, it would be $95 each, or somewhere around there. And then something for each child is not covered, their children as well. And that is to stimulate people to sign on, because the way health insurance works, you have a vast health system, and you want healthy people in the system as well as people who are maybe not as fit. Because if you have a lot of people who are not healthy in the system, the cost is exorbitant to the provider. But if you have a lot of healthy and unhealthy people in the system, it tends to balance it out because everyone is paying a premium. And so they have to encourage everyone to participate. And I'm sure that was a policy decision that they made to try and encourage everyone to participate in the system. So we do want to say that before the passage of the act, there were a number of people who just simply were uncovered. Now, the community's role, I wanted to say that it's important, considering what I've just said, to keep that in mind, to remember the bridges that have brought us over. The Affordable Care Act didn't just happen. It came from years and years and years of very determined work by a lot of people over many decades. We need to continue in the Black community to be engaged on the civil, social, and political fronts. We need to be advocates, and we need to particularly work to strengthen our social cohesion, because we cannot accomplish anything working apart. We must work collaboratively. We have to be aware and be vigilant about improving our health status. And as an African American in the community working, and I'm sure Dr. Randall, I see her everywhere, and she is one of my mentors. I do work with other minority groups, the Asian Americans, the Latino Americans, the Native Americans. When I talk to these groups, they are aware of what their health issues are. The leadership is aware of what the status is. Every group has people that just really aren't plugged in. But for those who are plugged in, who are willing to be leaders, who are willing to speak up, they are advocates and they are activists, and they're not ashamed to speak about their health issues. And they speak to power, truth to power. And so that's what their role is, and that's what they do. And in the African American community, we have people like Dr. Randall, who is a forerunner of this particular health disparity. She wrote the book. I have it on the shelf of my office. And if you didn't hear this in this presentation, I actually quoted her a couple times in this presentation from Dying While Black. But we have to have people who pick up the mantle, who are willing to stand up, who are willing to speak up, who are willing to participate, because people like me who are in agencies working need people in the community who are champions. Right. And we have to have those champions to get anything done. So be aware and be vigilant about eliminating economic conditions, because those are the major causes of poor health is social economic conditions. And we have to work diligently to ensure that all people in the community have jobs, are educated, and have access to care. But also we need to be aware of what those root causes are, because we can require our government, our city, our county, different agencies and departments to do their part at the policy level, at the systems level. We have to do our part as well. We have to make sure we have clean neighborhoods, safe neighborhoods, that our kids are going to school, that they're graduating, that they're cared for, that they're well fed, that they're loved. And we have to live our own community up in order to really have good health. All of this impacts good health. And so Joseph has already shared with you who to contact to enroll for the Affordable Care Act, so I won't repeat that. But I will say that if you're not enrolled and you're eligible for Medicaid, the Medicaid enrollment did not stop. It was the enrollment for healthcare.gov that had a deadline of March the 31st. And that's for people who have income, who are working, who don't have insurance, who should sign up for insurance. But if you have a lower income and you might here. And I want to give an example too. I have a friend who has a higher degree, a bachelor's degree. She was laid off from her job. She's always had insurance. And she went to apply online to apply for health care through the government. And she was offended almost that the system told her that she was eligible for Medicaid. Because people who've never been eligible for Medicaid, maybe they don't want Medicaid. Maybe they say, I don't want to be on the Medicaid system. But think about it. This is an opportunity for you to have insurance, whether it's called Medicaid, whether it's called Band-Aid, whether it's called Kool-Aid. It's insurance.
Right.
And you should apply for it, and you should participate. And not only should you, if you don't, there's a penalty for you not doing so. But, you know, just because your condition may not be what you want it to be today, and you may be eligible, what you think people have, you know, like welfare and Medicaid seems to have like a negative connotation to some people. But it is insurance, and it is out there, and you should apply and you should receive it so that you can prevent health conditions. The very stress of being having low income or struggling with those issues, stress in itself promotes bad health. So if you want to prevent poor health, you have to be your own champion, your own advocate. So you should apply and you should receive the help that's available. And I hope that people will do that. If you have questions, certainly you can call my office. And my number is 937-225-4962. 937-225-4962. I'll be more than happy to link and continue whatever resource you may need. Thanks so much for listening.
Thank you. A lot of change in the over. Say something here. And right now we're waiting, putting together Sister Professor VERNELLIA Randall's slide presentation. And as we were stating before, that what we're here to do is to give you information about the Affordable Health Care Act. And what you've heard thus far is a historical point of view on the history of Black health. And you've heard some of the reasons why we should participate and sign up for the Affordable Health Care Act, one of which, of course, is that if we don't, and from what I have researched and studied, is that that penalizing will increase as time goes on. As Sister CHERYL SCROGGINS said, that one of the reasons for the penalty is to encourage enrollment. Another reason for the penalty is that because it is a pool and it operates off of the inclusion of all to cover, then it also, that penalty goes to help to cover those who are may not be able to afford health care and to pay into it. This penalty also covers that area as well. So if we're ready, we're going to go to Professor VERNELLIA Randall and hear her presentation.
Thank you. Thank you so much for inviting me. I'm sorry that I don't have the slides here to show to you, but I can talk from it, and there's some things I want you to hear and hear. And I really appreciate this. I am a systems person. My whole life has been looking at how to use the law to change the system in order to improve Black health. That's the approach I take. And so the question I have is the system fundamentally changed, and will it improve Black health? Okay, and the answer is that no, slightly. No, the system hasn't fundamentally changed, and I'm going to talk to you about why. And because it hasn't fundamentally changed, it's only going to have marginal improvement on Black health. Number one, for the very reason that Ms. Scroggins said, the primary problem for Black health is not access to health care. It is living on top of toxic dumps. It is living in noise-ridden areas. It is food that is old and dated. It is living in food deserts where you can't even get the food. It is having education, not being able to get the education and being suspended from schools and ultimately dropping out and becoming a dropout. It is jobs that only go half-time or partial time and only pay you minimum wage, so that A, you can't get a second job like when I was in my 20s and was working a part-time job. You get two jobs because A, you can go to job one, and B, you could go to job two, and between the two, you had a full-time salary. But nowadays, what they do is the employers want to capture individuals for their employment, and they schedule you in ways in which makes you impossible to go out and get a second part-time job. And because even though you are part-time, they want to treat you as a full-time employee, even though they provide no benefits. You know, so many of our community are working. They're just working on these bad jobs. And the system isn't doing anything to change that. And healthcare isn't going to change that. And fundamentally, the fundamental cause of poor health, as CHERYL said, is racism in American society. Because when you think about it, the difference between middle-class Black Americans and middle-class white Americans is not in how they live. We all do the same bad things. We run if we run. We eat from the same food stores. It's the difference between poor Black people and poor white people is not in how they live. You know, people complain about poor Blacks who eat shit, and they say that we don't eat right. Well, poor whites don't either. It ain't like they going and buying steaks and we buying chitlin. They're buying pig feet. They're buying cheap cuts of meat, just like the poor people in our community. So it is not about how eating. Poor white people don't have places to run, just like poor people in our community don't have places to run. So it's not, poor white people live in food deserts, just like our people live in food deserts. It's not about the habits that we have that causes disparity. Now, understand what I'm saying. I'm not saying that there's not things we can't do to improve our individual health. Obviously, we can eat right, run, and individually we can do that. When I used to be a public health nurse, the first thing I would say to someone who was my size, who sat down in front of me, is you need to cut down on some of that sugar and stuff. But I had to know that telling someone like me that was pretty meaningless if the situation in which they lived didn't change. And so we've got to focus on systems even as we work with individuals. So when I look at the healthcare the Affordable Care Act, I want to ask myself again, how does it change the American healthcare system? Well, part of you have to understand is we don't have a system. We have literally 4 systems. 4 systems. A good resource is Sick Around the World. It's it's a PBS resource. Go on. It's a good journalist flew to 5 capitalist countries to look at their healthcare system, and he also wrote a book on this. And what he found is that there are 4 basic systems. Generally only have 1 system. They make a choice. We refuse to make a choice. So we got 4. Countries have, and the 4th one you find in poor countries. And we have that 4th one as well. What are those? Sort of a national health insurance plan. And a plan that provides you insurance, but not necessarily insurance, because you have to remember, insurance is not access to care. Insurance is the ability to pay if you can get in, if you get into the care. And we know in a capitalist country that ability to pay can be a way of rationing. So it's a big thing to have insurance. Okay, so you can have national insurance, and we have that. It's called Medicare, and it's called Medicaid. And Medicaid is an entitlement program, but still it's an insurance program. It's not, Medicaid guarantees you nothing but the ability to pay if you can get into a doctor who will take your Medicaid. Same thing for Medicare. Okay, and I'll talk in a minute about, they function differently. So we have the National Insurance Program. We have a market-based insurance program. Okay, let me say a little bit about the National Health Insurance Program, which, well, no, I'll go on to the market-based. Market-based insurance programs are insurance programs either through employer or through somebody's buying the insurance, either the individual's buying the insurance or the employer's buying insurance, but you have the employer, you have that. Since we have a system that's based on employer-based insurance, a primary focus of employer-based insurance, individuals who have employees, who are employees, don't really get to control the insurance they get. Most people don't realize that because, you know, your employer controls the insurance you get. Now, they may put together a committee, and they may, you know, but they don't put it up for vote. And I remember when Dayton decided they were going to move from fee-for-service to only preferred provider plans. And what they did was they started making the fee-for-service so high that nobody would choose it. And then once so few people chose it, they said, oh, you know, we'd like to afford do this fee-for-service, but nobody's choosing it. It's too expensive for us to keep. And I said to people when they started it, I said, you see what they're doing, don't you? They're pricing us out of fee-for-services, and then when the numbers get so small, they will claim that it's because nobody wants fee-for-service, not that we priced you out. But employer-based insurance is employer-controlled, okay, not employee-controlled. And so we'll talk about what that means. Everyone who has a job and have insurance knows that. You know, you don't get to say, you know, what's in the insurance plans. They tell you each year what they're going to do, and you get to pick from the choices they say to you. But other than that, you don't really get to go out on the market and say to the employer, here's the insurance I want, and give me $150 for that. The other system is the government health care system. Now this is not insurance, this is health care. We actually have 3 healthcare systems, government healthcare systems. Military, you were in the military.
Yes, ma'am.
And the military they provide you the health care. You know, there is supplemental insurance for things that you might want to get outside, or if you oftentimes, for instance, they provide it for your dependents, and maybe you're stationed somewhere where they don't have a lot of OBGYN doctors, so they will pay for you to go to an OBGYN. But basically, the services are provided for you. So that if you want to know, if anyone says to it, we don't do health care, we don't provide health care. Yes, we do. Military, veterans is a system that is both an integrated insurance system, but also primarily a healthcare system. I am not attesting to how good these work, because they all work pretty bad. Okay, and that's fundamentally the problem. And then the Indian Health Services, which no one ever really talks about, which is a treaty obligation, which is continuously underfunded. Significantly underfunded. So that under the treaty, Native Americans are supposed to get health care, and the United States government funds it as little as possible to be able to say, well, we're meeting our treaty obligation, but it's poorly funded. And then so those are the 3 systems that you will find in any developed rich country. Okay. The other system that you find that we have, which is only in undeveloped or underdeveloped, poor or moderately income countries, is the pay-as-you-go system. You have to pay for it. Okay. And that's what all uninsured has been. They have been in that system. So the cost in our system is from having 4 systems. The cost in our system is for not being able to regulate the prices that can be charged, our unwillingness to regulate. And the reason people don't like Medicare is because Medicare is such a big buyer that they can demand that price, that what people charge come down, and they do it. Okay, so that's the basic system. I want to play this. I want to play this short video. I hope you can hear it. Okay. Can you hear it? I'll just talk, and then I'm going to try to play it. So, Taiwan became rich in the mid-1990s. And the first thing they said was, what every rich country has is a healthcare system. They assure healthcare for their people. So we're a rich country now, we need a healthcare system. So they put together a blue ribbon commission, and they did what we did not do. They studied the healthcare system. They studied about 10 to 15 countries. And ultimately, as the woman said on the video, what they decided, because they have, this was said on the video, they have this Chinese proverb. They said, being a small country, they can't afford to experiment. They have to look at what succeeds and what don't succeed, and then make choices in a way that will make them more successful. So they have a Chinese proverb. It's like if you're traveling in a wagon, look at the wagon in front of you. Do what they're doing if they're successful. Don't do what they're doing if they're not successful. So they looked at all of these countries. And so the reporter asked them, and I find it really funny. So did you look at the United States? Is this quiet? The guy he's talking to gets silent. The guy said, yeah, we look at the United States. We thought it was the best system in the world, but it's not. And he said the problem with the United States is that it's not a system, it's a market. Understand what that means. We don't have a system of providing people health care. We have a market for providing ability to pay. And that we kind of go with the market. And the problem with the Patient Affordable Care Act is it tinkered with the market, but didn't fundamentally change anything. And so, yeah, what they did is, I think, and I'm sure CHERYL will disagree with me on this fundamental payment in terms of how we pay doctors, but we've already been moving towards that in the existing system. So we're already we have moved away from fee-for-service over 10 years ago. In fact, when I interviewed for my job at the University of Dayton in 1990, I wrote my paper on managed care, and I predicted that fee-for-service would no longer be available to middle class. And I remember what one of the professors said, because he looked at me. He said, oh yeah, that's going to be true for poor people and black people, but it ain't going to be true for us who can pay. And I said, no, you don't understand. You won't be able to pay enough because the only way insurance companies can control and make a profit is not through fee-for-service. They got to push everyone out of fee-for-service in order to make a profit, because in order to make a profit, they have to control what services people get when they get it. And that's what, and I'm using managed care in a really broad sense because I know that they differ significantly, but they all have the same kind of roots. The root is I'm having a senior moment. The roots are really I'm having a bad one. What do you call it when you pre-authorize or post-authorize?
Mandated?
No, I'm talking about pre-approval.
Pre-authorization.
Yeah, but there's I'm not thinking of the word right now, but it used to be that when that's okay. It'll come to me in a minute. It used to be when you'd go to your doctor, you walk in, you see your doctor, you eat the cake, okay? And then the insurance company would say after the fact that yes, you could that they would pay for it or not. But the fact is, you had already ate that cake. Whether they pay for it or not, the cake is eaten. And insurance companies realize, I mean, not just insurance companies, because this is a matter that's beyond them. People realize that they have to have control on people's eating the cake. They have to stop people from going in. And so they, instead of having post, they moved to pre-authorization. Take a look at how much stuff has to be pre-authorized. And that pre-authorization is so that the insurance can say, no, we ain't going to pay for it before you go in, and then you can decide, well, I don't know whether I can afford it. Okay? And you will decide that. That's the whole point of that. So through co-pays, through all of this stuff, it's sort of to make you aware. And I'm not saying that's a bad thing. That's just the way it functions. And we move from a fee-for-service, and this is what we moved into. And yeah, Patient Protection and Affordable Care Act is trying to build in some quality things, but it doesn't fundamentally change how people function under those systems. The other thing it did that has happened in the system over the last 20 years is that when you doctors and hospitals have a legal obligation to the insurance companies. That wasn't always true. It used to be that doctors and insurance companies, you contracted with your insurance company, your insurance company contracted with you, and they had no relationship to the doctor. The doctor contracted with you, and the doctor had no relationship to the insurance company. But now all the insurance companies contract with the doctors. Now, so doctors and hospitals are under contractual legal obligation to kind of abide by the standards of the insurance company. And they get what's, I'm using this as a broad term because I know it doesn't, capitation, meaning they get a certain amount of money and whether you see them once or twice. So they kind of have what the insurance companies have done is built incentives for doctors to give less care, direct care, okay? Because they don't get paid the full amount anymore, and they get paid and they get evaluated on whether by the insurance company standards. Nothing's changed about that, okay? We just moved people into these systems, and we've enticed them to move into it by doing some things that people want, which I think are important. I think saying the pre-existing condition, getting rid of that is an important thing. Lots of people now have access to health care because now insurance company can't deny them based on pre-existing condition. But the problem is that this system, which has 4 systems in it and subsystems within the system, you need to be highly informed in order to get out what you need. So you can't just go out and buy the cheapest health care, because if you do that, you're going to end up in the same situation you are now, which is the providers you need to go to aren't on your plan, because one of the ways the insurance companies make those plans affordable is they do a restricted panel. I read about some areas where the only 2 children hospitals in a community, and the plans only contracting with one. Plans not contracting with the only specialty surgeon in a community. Now, you know, there can be all kinds of reasons why that's so or not, but for us, what that means, first of all, we don't have a lot of providers in our communities. And if you don't sit down and figure out who are the providers they're contracting with, when are they in our community, how often are they in our community, and you might find yourself having to travel out to Centerville to get care because your provider is out in Centerville. Or they only come here 1 day a week, and that happens to be the day you got to work. You can't take off of work. I got a provider who only comes into Dayton 1 day a week. I mean, I don't think that's going to be a big issue for people. They're going to have the ability to pay because they have insurance, But they won't have access because they don't have providers in their community, or the providers don't come at a time that they can afford it and can do it. And let's not even go down Medicaid's road. We're pushing all of these people into Medicaid. And we know there's an existing problem with Medicaid that was, as far as I know, correct, because the plan is so deep, nobody can know everything. One of the big issues with Medicaid that has been a long-standing problem is providers refusing to take Medicaid. And so you're pushing all of these people into Medicaid, and people say, hey, I don't take Medicaid. Now, they could fix that. And there was many of us who lobbied to have them fix it. They could have said, if you take any insurance off the exchange, any at all, you have to take Medicaid. You can't refuse Medicaid if you take it. We ain't telling you you got to take exchange. And we're not telling you have to take Medicaid, but we're tying the two together. They didn't do that. They didn't fix that problem. So we're still going to have the provider refusing. They put in a clause about not discriminating against providers. And I don't know what that means. I hope it means that insurance companies won't be able to do economic credentialing. Do you know whether? Okay. Okay. So the economic credentialing, you got the degree, you got the quality, you have the expertise, but you are charging too much. Your patient, you ordering too many tests, you charging too much money, and so they kick the doctor off the plan because the doctor is economically costing them money. The courts have help that they can do. That's called economic credentialing. That they can say, we're not going to put you on the plan because you cost us too much money. I don't know how that plays out for our community. Yeah, because we're sick. And we need a lot of tests. And we need a lot of care. And so anybody practicing in our community is going average. Are they going to make it culturally? Are they going? Nothing in the plan is in the Obama. I'm sorry. I'm one of the people who call it Obamacare because I don't like it. Nothing in the Affordable Care Act deals with the economic credentialing and provision of care for communities who are sicker. There's a lot of good health disparities things in it, but none of that kind of stuff. There is some things related. One of the big issues about whether or not we are going to have access to quality health care is actual providers in the community. Now, there is some workforce type of information in work on the workforce, and there is some building community health clinics. But there's nothing, and this has been one of my big complaints of everything that Obama has done during his regime, is that he does not require the agencies to look at the racial impact of the choices they make. So there's nothing in there that I can see that is going to actually, all this money is going to go into community health centers. How do we know that the Black community is getting in those community health centers, are getting proportionate to their need? And since we have a great need, we are underserved and oversick. Okay, what is going to happen with that? So Medicare, one of the big issues people are promoting Medicare for all. As a person on Medicare, I love my Medicare. So that's all old people say. They look at Medicare. And one of the big issues is why didn't we just make Medicare for all? Just a national health insurance. And this goes back to the idea of a market. We have an insurance market that makes profit on the delivery of insurance. Okay? Now let's sink that in. If we had a completely non-profit market where the insurance companies didn't make profit, it would be a little bit better. But as soon as you say, saying insurance makes profit on healthcare, insurance makes profit, it's like saying private prisons for profit. There's only one way to make money in private prisons, putting prisoners in there. There's only insurance can make profit, and that is controlling the cost. And the question becomes, which community is going to have the cost control? I give you an example of what happened to me. When my son, who's in his 40s now, was a young adult, he has a knee problem. I took him in, he had to have surgery, and he's a big man, like 6'7", like 300 and something pounds. So he had to stay around 11:30 at night, and they came out to me and said, "You can take him home." I said, "I'm not taking him home." And they said, "Well, this is not an overnight stay." I said, "Well, I'm not taking him home. I don't think he's capable of going home. He just got out of surgery, and I don't know whether he's going to walk or not." And so I said to someone, I didn't look like so they went and out and came back, and finally they just sent a doctor out to talk to me. The doctor started talking in a slow voice. You know how they do when they think you don't understand anything. So, modulated voice. And so I thought, okay, I remember this. I closed my eyes, I shook myself, I sat up straight, I took on my I am a lawyer and a nurse attitude. And I basically said to her, I'm a lawyer, I'm a nurse. If you think my son is ready to go home, I'll take him home. You write in his chart that you are discharging him over the objection of his mother, and his mother's specific objection is that she thinks he is not ready to navigate by himself. If he falls and hurts himself, I'll sue the hell out of him. She looked startled, walked back in, gone an hour and a half. What did they do during that hour and a half? Contact their lawyers for risk management. What did they come back and tell me? He's admitted. Now, did I need that? No, my point is, did I need that? I don't know. But what I did do is use up some profit if it was unnecessary. And someone's got to they're going to recapture that profit somewhere. And the place they're going to recapture it is on people who aren't nurses, who aren't attorneys, who don't know how to navigate their rights. Who don't know that when you get a denial, you just keep resubmitting it over and over. You just keep pushing it up to change, because sooner or later they're going to get tired of you and say, okay. You get someone who can work with you and help you understand the details of what you're reading. Don't just let the fine print throw you off. Okay, so I'm going to stop so people can ask questions or talk. My basic problem, we did not move everybody out of the pay-as-you-go system. We still have a large number of people who are in that system. We didn't fundamentally change the other three systems. We tinkered around the edges on them. And every other wealthy country has learned that you gotta pick a choice and go with it. And when you do, you control forces. Like Germany, for instance. Germany has 240 insurance plans. They have a national, but they control their costs because their insurance plans are not allowed to make profit on the basic services and the health care. And in this Sick Around the World movie, they asked an insurance agency, well, what do you do? You're a for-profit company. What do you do? And he said, well, we compete for their other business. We want to get them as insurance companies because if we can get them as a health insurance person, then we can sell other stuff to them. We can sell other, things that are not covered in the basic plan, that sort of thing. Anyway, so I had a video showing Senator Kennedy. Oh, one other thing I want to talk about. I think the plan is awful when it comes to dealing with racial discrimination, and that it's going to be totally ineffective for eliminating racial discrimination in healthcare. And the reason it's going to be totally ineffective is because it throws in a clause, but it ties it to Title VI, and Title VI is ineffective. And in this conservative court, all they're going to do is look back at Title VI and interpret this new plan in light. I pleaded with them. I talked to a representative out of Senator Kennedy's office. I talked with the people who initially drafted. I said, this is so wrong. It's going to have big problems for the Black community because we are already discriminated against in this provision. And I was told, not by the Senator Kennedy people, by the National Health Law people who drafted the discrimination clause, he told me, look, we wanted a broad-based clause that could be freely interpreted because we're trying to get coverage for lesbian, gay, transgender people. And so we figured if we put a broad-based clause in, that then it can be argued that they're included. I said, yeah, but by doing it the way you do it, you are not affecting. Blacks now have no way into the court, which is a whole nother lecture, on racial discrimination in healthcare. No way into the courts because Title VI is so bad. By tying this new law to Title VI, you bring that history into this. And he said to me, without me, you don't have nothing else, so what difference does it make? So this is, individually, there's going to be a lot of people helped. In 10 to 15 years, this law is going to be horrible for the community, and the impact will be known because it takes that long for people to collect the statistics and hear it. And the problem, this is my belief why doing something is not better than doing nothing. When you live in a society that will only correct the problem that's based on race, when they have the problem too, then it's better to do nothing until the problem gets so bad that they have to do things that you've done. Right now, we've corrected a problem, but not the core problems for our community.
So are you saying we corrected the process, but we haven't corrected racism in healthcare?
We haven't really corrected access. All we corrected is the ability to pay if you have health insurance. That's all we corrected. So if you got a doctor, if the doctor takes your insurance, if you don't end up buying the cheapest insurance there is in having that. One other thing, we don't even know how this is going to work, but one of the things I think is going to happen is people are going to find out they really are in the same position as being those cheap plans. Because if they go out of network, if they get sick and go out of network, because that's what people do, not only do the lifetime limits not apply anymore, the insurance limits don't apply anymore, and you could end up in bankruptcy just like as if you didn't have health insurance. Because going out of network voids all of those limits. The limits don't apply to the out of network care. Okay, thank you. As far as I can understand, some of them I got, but that's not so big that I can't stand corrected.
Well, thank you, Professor Randall, and thank you all for informing us. And now we just have a few questions on the Affordable Health Care Act, and some of them I have already written down from individuals wanting to ask these questions. The first question is, what day does coverage actually begin? Does it start when the application is complete, or does it start with the first payment? And any of you?
Okay, on that one, generally you'll get a letter from your company saying when coverage is going to begin. Typically, that is the first of the month.
Okay.
Is when they have that, and then you do have your premium that you have to pay. So, that coincides with that there. But generally, typically at the first of the month, generally when coverage are in, it's typically at the end of the month.
Okay. All right. And so you're saying that once you fill out the application, are you automatically covered, or?
Well, under the Affordable Care Act, if you were going to pay a premium and everything, you'll go through that process and you do an application with the company, and then they'll give you a notice of when your payment is due and when your coverage is going to take place. On Ohio Medicaid will actually send you a letter stating when your coverage begins, and they will give you it. And typically that's at the first month letter. They'll tell you this is when your coverage is due. And Ohio Medicaid, as long as your case is active, as long as you are deemed eligible for Ohio Medicaid, your coverage is still intact.
All right. And if you all have any questions, just please don't hesitate to ask. Another question was, are applicants notified that and I think you'll just answer that question, are applicants notified when their coverage begins?
And again, they should be a letter from the state. If they've applied for Ohio Medicaid or going to pass over for Affordable Care Act, you get a notification. They should get a letter from the state stating that they are currently, they're now being eligible. And then that's when they go into the process of actually choosing which health care plan that they're going to go on, which they have an option of choosing here in Ohio. So a lot of things take place right during that time.
Okay.
I don't know what it is, and if we were someone looking in, there is something wrong with Ohio Medicaid. My son has applied for it and was told, that there's problems in the system or something. I don't know what that is.
Well, which website you talking? The Affordable Care Act website?
No, the Medicaid.
Ohio Benefits. This change that they recently did with the expansion of Medicaid is actually affecting about 300,000 folks statewide, just on the expansion of Medicaid. It is, and we've got reports that there are some backlogs in the system because just the word has really gotten out now that people can apply and get on there. So I think right now they're really just trying to work through the backlog and get everybody, even calling in to make your selection. People have had trouble doing that because just the volume of coming in. I kind of use this equation for folks. If I built a gas station out here, say over here, we're close to Wesley Center, if I built a gas station over the old Corvus is at, and I put in 2 pumps, okay, and I'm charging, I don't have the capacity to take care of it. But I think, right now, I think they're working through the capacity issues. I tell folks now, there is light at the end of the tunnel now. At least, before we had no opportunity to have access to health care or even to be able to say, hey, you have health care. Because, like I said, particularly for about, young single men and young single women, they, who are out there working, they had students going to school or whatever they need, and they're out here working 2 or 3 jobs. They had no opportunity to have health care. So now that option has been opened up, and folks are taking advantage of it. That becomes that process of educating them to value that health care. I've talked to a lot of groups, and that's one of my main things. I said, now you have health care, take responsibility for it. If you have appointments with your doctor, make sure you get to those appointments. We want you to get checked out. We want you to embrace the preventive care. When I talk to folks, I'll look and say, I see you wear glasses. When the last time you had your eyes on? Right now, when you come on, don't get those preventive type things done. Get yourself looked at. I mean, I go to the doctor every year, but I'm used to that happening. I was in the military 30 years, so every year I went, whether I wanted to or not. But I went in, it's just educating them, getting them in. But there is a background, just because of so many folks. But just be patient with it.
Oh, yeah.
I have several questions. The first one, with the economic credentialing, a lot of insurance companies are using the Medicare fee schedule, so they don't care what the doctor's charging anyways. They're going to be paid a flat amount according to the fee that fee schedule. A question that I did have about Medicare is we have a lot of elderly and disabled people who have Medicare. And how are they paying for that Part A deductible, which now is like 12, 16, and it goes up every year, most years. That's a huge amount. Not only are they paying the Part A deductible, they're having to pay that Part B deductible or any co-pays or anything that's out of pocket that they cannot afford. So how do they, you know?
There's a lot of Medicare is expensive.
Right, but how do you tell an elderly person or a disabled person they have to not only have Medicare, but they might have to have a card out or a.
Do you mean how do you tell them, or do you mean they shouldn't have to be told?
Well, I mean, is that explained to them? I don't know. I'm not.
Yeah, well, first of all, I mean, no, part of the problem is people with if you're elder, my brother-in-law doesn't have Medicare Part B because at the time when he was eligible for it, he decided he didn't want to pay out of pocket for it. The problem is a huge penalty that goes with Medicare Part B if you try to come along years later and jump in. And so now, you can't, if you don't get it at 65 and you come at 73, you're going to pay a lot more. I mean, that fundamentally, this is some of the problems. I think, we have these systems that cost money, and even if I don't know. I mean, that's just part. People don't know. People don't get the right information, and people don't make the right choices. So Medicare, and they are doing it in the Affordable Care Act.
So can a person on Medicare, can they have Medicaid as a creditor?
If they qualify for Medicaid, that's called dual eligible. Okay. And if they are poor enough to qualify for Medicaid, they can get Medicaid. Yes, they have to apply for it. Now the problem becomes, and this is something that I don't even know how they're going to work out. They're putting all these people on Medicaid. The problem becomes is not only does Medicaid have income eligibility, they have asset eligibility. And that if you have too many assets, like you have a house or a car or stuff, I don't know exactly how it's working now, but generally, unless your assets are exempt, you will have to spend down your assets before you can be qualified for Medicaid, even if you're unemployed without income. Now, I don't know if they're generating a rule to change that. The other problem with Medicaid the Medicaid to our community is that there is an ability for Medicaid to go years later and tap your assets. So you can go in now and be eligible, but you might end up when you have assets being, unless they change the rules, just like the IRS is trying to go after some people, Medicaid has been over. So yeah, you can. The answer to your question is an elderly person who is poor can get Medicaid if they apply for it and their income and access and asset eligible. A person who's in their 60s ought to start planning for it by looking at how they want to move around their assets before they need it, and doing some financial estate planning. And even if you don't have a lot of assets, people don't realize that all you got to have is some money that you want to go to your kids, or a house that you want to go to your kids. That's an estate, and you probably need to see a lawyer or talk to someone who's familiar with the rules to determine, because there's ways to protect your money, but there's a penalty if you do it, and the penalty is like 4 or 5 years. So you do need to do some estate planning in your late 50s, early 60s.
Yeah, I was going to say that's something that we don't do enough of in our community, is estate planning. But this is a very common type of thing that happens in the white community. A lot of people plan they plan how they're going to, what they're going to do with their assets years in advance of them entering into any system, and they're able to deed their house. They're able to, create some type of a trust fund for their family members, so that they don't lose their assets in their later years. And so this is a really recommendation from Dr. Randall that we do that. I wanted to say too that many people are not aware that there are some exemptions from the health insurance marketplace. There are things that you can legitimately be exempt from having to apply from the marketplace, and it might behoove you to go online to the federal website and the insurance marketplace and look some of those exemptions, because there are some things that will enable you to not have to apply at this time if you don't think it's appropriate for you. But you need to know what those exemptions are.
For those people that live on state lines, like say you live in Ohio but you work in Kentucky, where do they apply for? Do they apply for the insurance in Ohio or Kentucky?
Where's their residence?
Ohio.
And they apply in Ohio.
And even though they spend most of their time in Kentucky,
We said they're working
or
there.
they're working in Kentucky and they're paying taxes in Kentucky,
But where's their residency?
Ohio.
Okay, then that's your state of residency is the place where you go. Not just, you can do all this stuff in another state, but what state do you claim as your residency state?
Okay. I just have one more question. Is that okay?
No, but
Yes.
Any more questions?
Debit cards. A lot of insurances give you debit cards to pay for like over-the-counter medication, co-pays, things like that. Will the Affordable Care Welfare Act change the reimbursement process for these type of services?
So you're saying some companies do debit cards?
They do a debit card.
Yeah. See, each company operates independently on the services that they choose to provide. So it's really up to that company, because they're getting the money that they're collecting. They decide how they're going to distribute that, how they're going to, what healthcare things they're going to do, what incentive programs they may have. Each individual company, so that should not affect it. The company will make that own individual call on that, but what incentive programs they may have. So, like I said, they receive a certain amount of dollars, and they go from there.
I'm a mental health provider, and I was wondering how I go about being a provider for the insurance plan.
Well, actually, you can reach out to each individual company or whichever company, because really the companies have the option of deciding, their network, who their doctors are. I was speaking on behalf of CareSource. We contract with hospitals, okay, and with providers. We contract with Premier or with Kettering or with children, and we have an actual written contract stating what things are going to be done, what expectations are. And same with our providers. We have a list of providers that make up our network that you can look in there and choose which doctors. They have to be in the network, but you choose which doctors that you want to, that you would like to go to, whether it's our doctor, whether it's a dentist. But those things are in there, so you can actually reach out to the individual company. I will make sure you can have my card when I get done. And you send me your information. I'll make sure it gets to the right folks.
Again, I'm a provider.
Right, that's fine.
You're saying that I should connect with those hospitals?
Well, or the individual health insurance companies.
Okay.
You can contact them and say you'd like to be part of their network.
Okay.
So, like I said, I can make sure I can give you our information, but you can look to see which other companies you may be interested in joining their network, and then they can look at that and see what their capacity is.
It's part of the issue for our community. If you're not a part of their network, then the insurance that the community decides to do, and you can be a part of a lot of networks.
Yeah, you're not limited.
Yeah, you can, you can be a part of, it's up to
unlimited,
you.
right?
Yeah. It's limited only by the amount of paperwork you want to do, but the provider has to take responsibility of going out and getting on the network. Now, the insurance companies may be reaching out to some, especially large practice providers, but individual providers may find that they have a lot of work to do to get on this network.
Okay.
And that's going to, and the problem becomes, and they're talking about the impact on the African American. Many of the providers in our community are solo providers without support networks so that the cost of reaching out, applying, this might be an opportune time to form a providers co-op that actually pool your money together for community providers here to research the different insurance companies and what it needs to be on them so that everybody's not doing it individually.
And I think it's important too, as a minority provider, that you participate with these large systems because you are able to provide services in a very culturally competent way, and we need minority providers.
Remember when they changed the rules on that because for mental health providers or mental health services, that's the only service that you cannot go back and do any virtual for. You cannot bill for a service that was provided yesterday because mental health is the only one that you can't do that. Everything else that you need pre-authorization for, and did you get a pre-authorization number for, you can go back and back bill those and reduce the patient's out of pocket. But for mental health, you can't. I never understood that.
That's one of those Medicaid rules or state rules, whatever. But I know they do go back. Medicaid does on certain things, but that's their rules on how they handle that.
But for a lot of insurance companies, because I was an insurance collector, so for a lot of insurance companies, that's the only thing you cannot go back and do a retro.
Well, I'll speak on behalf. CareSource has you when we have you. If you're coming on the 1st of June, we have you midnight 1st of June moving forward. We have no responsibility prior to that because you're not a CareSource member. Okay? Just like we have you to, if they say your coverage ends September 30th or 2014, we're responsible for you that whole way there. So, and that's the way that.
I guess, I'm not understanding what you're talking about.
If I have a visit today,
right.
There's a lot of private insurance companies. If I have a visit today, I need to see a mental health provider today, and it was not authorized.
Oh, okay, you're talking about authorization.
It was not authorized.
Oh, you're talking. So you're saying they're a member of the company, right?
You're a member of the company.
Okay, gotcha. Okay,
or your wife if your spouse is
right.
covered somehow. A lot of insurance, actually most of the insurance companies will not let you go back and back bill for that services that was
because of prior authorization.
Right, because of prior
authorization. Okay.
But the whole prior authorization thing, you see the problem, the thing is the whole, excuse me.
Different thing. Now I got what she's talking about.
But that's not, it's just mental health because
but
that's specialized service and have it authorized.
But I think that that may have just been the fact is companies have refused to backfill prior medical stuff that hasn't gotten authorized. In fact, a lot of people it's not just mental health.
But if you think that services were, if you can prove that services was needed, you can show it.
No. The issue is, did you do what the insurance companies say you need to do? And need is only one of the things. The other thing is getting prior authorization.
But sometimes you're not going to know it.
I'm not arguing with you on that, but what I'm just telling you, because this is the problem with moving this in, instead of having a health care system and having an insurance system, this is the problem of the difference. The difference in a healthcare system, if we had a healthcare system, you would go in, you get the healthcare, and when you have an insurance system, especially a profit insurance system, you gotta abide by the rules, and you gotta read the rules, and you gotta know what the rules say, and they can deny you based on not following the rules. You need it.
The problem is yesterday I didn't know I need help. Today I might need it. I might go slide my chair over to go see her, and because it wasn't pre-authorized, she's not going to be paid.
So what you should do is, before you slide your chair over there, take out your phone and call your insurance company.
Yeah, and you.
Yes.
Also, the provider knows.
Now, if it's an emergency, there's always emergency exceptions, but there's no way around this. This is the system. This is why I look at systems. This is the problem with the system. Yeah, okay. And the question right now is how to deal with it. And the answer is know the rules and don't go seek care until you have gotten your pre-authorization.
Right, but our children, I mean, our
Okay, I mean, I'm not arguing with you. Okay.
Okay, and this goes back to the point that Dr. Randall made earlier. We have all these people going into this new system. They're applying for a particular plan, you know, gold plan, bronze plan, platinum plan, whatever. But they need to look at what's in that plan that they're electing and not just go on, oh, that's the cheapest one. That one only costs $143. This one costs $148. Because you have
I'm
to look
gonna save
at
my $5 a month.
you have to look at the deductible, you have to look at the premium, you have to look at how many visits you get, what your copay is, and a lot of people are not accustomed to having insurance. So this terminology and just the way to behave with the system, to interact with the system, is just foreign. So what we're saying is, we need more forums like this, and we need people to come and hear how to work and understand how these systems work, because how you engage that system should end up costing you a lot of money, even though you have insurance, if you don't do it according to the rules.
I think we actually need forums that actually tell people to come in during the open enrollment period, and we will explain.
Yeah.
We will explain.
And I had some of those. I've had some of those.
During the open enrollment period.
Do you know those are?
The next enrollment period for healthreform.gov is November of 2014.
Okay.
Yeah.
But between now and 2014, not wait till 2014, November, between now and November, we should have forums where people can come in and understand how exactly the system operates and what they'll be getting when they select the system. And I know probably you have informational service sessions. Public health has informational sessions. And some of these providers you see on the wall here also provide information sessions on just that.
And this is the thing is, we got to look at this. When you start looking at companies, you'll say, well, they're all health insurance companies. But that'd be like saying they're all cars. But there's a difference between whether you have a Yugo or a Cadillac. You got to get under the hood and see what's actually in there working. And every company's different. Now, I would tell you, you talk about profit. CareSource is a non-profit healthcare company. We cover over 1 million lives here in the state of Ohio. We've been around for 25 years. Our whole mission has always been access to health care from day one. Our mission was built upon that. Our administrative costs that we keep for our company, our model for our administrative costs for a nonprofit is generally around 5 to 6%. That's where we hold ours at. We're a nonprofit, so we have a foundation that gives back into the community every quarter. We give out grants on health-related issues. We do that every quarter. So our mission is different than other companies may have. Companies that are for profit, because they're for profit. They have to cater to their stockholders. They have to pay stock dividends and things like that. Our company is different. So you have to really look at that, because what's under the hood is what really your services are provided. A lot of the services that we provide don't need prior auth. Someone needs to go to the doctor. Someone needs to go get an eye exam. They need to go to dental, vision, something like that. Those are not, they're no prior auth. They can just go in and get that done. We have 24-hour nurse lines where they have access to call and talk to a nurse 24 hours a day. In case they have a question about a medical issue, or I'm not feeling good, or I'm not sure, but they can call and talk to our nurses 24 hours a day. Just pick up the phone and call them, and they're there to help guide them on what's going on. If it's an emergency, they're going to tell you, go to the emergency room. So it is, a lot of education needs to go on.
And one of the things I think that is that people have to do this every year.
Yes.
Because the insurance plans change and your needs change. And so you've got to reassess every single year whether or not the choice you made last year is still valid. There is no brand loyalty in insurance. No brand loyalty. Just because you've been with them for 3 years, 1 year, 10 years, as soon as you look and see that they're no longer doing, or that they're doing the same thing, but someone else is doing something better. And I think there's things that you want to look at besides, in addition, is how are they rated in terms of how quickly they give authorizations, what percent of denials they have, I mean, there's kinds of things, we can't go in all that now, but the idea is that we could have had, for me, to go back, we could have had a system that didn't put all this burden on the individual. We could have. There's plenty of systems around the world that don't put all this burden on the individual. By making a system that puts a lot of burden on the individual, we set it up for people who are less informed, who are sick, who are stressed out, who whatever, to make bad choices and then have to suffer the consequences of those choices.
And our system does require that. The onus is on you to read and read what all the benefits are. The system assumes that you will
Follow through.
reading yourself.
Yeah.
It does.
And brother, if you have any questions about the Affordable Health Care Act, also known as Obamacare, you want to formulate some, you know, just raise your hand and ask. Thank you for coming. Sister CHERYL, how does the Dayton Council on Health Equity, Public Health, how do they assist, you know, individuals who want to know more about the Affordable Health Care Act? And can you talk about some, in another presentation you did, you talked about the obstacles, even if we do have, and Sister Professor VERNELLIA Randall touched on some of those obstacles. Can you talk about some of those obstacles as well?
Well, one of the things I do is I link people to the services that are available. And so if someone calls my office and they want to enroll in the Affordable Care Act, I link them directly to our community health advocates who help people enroll. They do an enrollment assistance. Another thing that I do is I do events in the community, and at that particular event, I will have certified application counselors there on hand to provide education sessions and also to do enrollments. And so I try to provide them the one enrollments that I have done. I've used the libraries, East End branch, Huber Heights branch, St. Paul's UMC Church was another site that we did information at, and I'll have someone get up, make a presentation, answer people's questions, and we're in a Wi-Fi environment so that they can actually go online and go on the system to the site and actually begin the enrollment process. So we enroll quite a few people during the month, the Minority Health Month. And I am continuing to link it to our community health advocates who are certified application counselors.
Excellent.
And may I say, too, that I intend to have some other sessions. I think this is a good forum, and we need to have other forums like this and invite the community out for these presentations. And so I know Joseph is in the community a lot doing these presentations, and we're going to try to work collaboratively with other partners to have a few more before November.
We would definitely like to be a part of that. Those, and I think it was Professor Randall who talked, I think it was you, Sister CHERYL, that talked about a friend of yours who was surprised that they qualified for Medicaid. And there have been in America right now a lot of people who have been unemployed for a long period of time. So when they do apply, and how should they apply, I guess, you know, because many people are just doing part-time jobs right now.
Well, you know, and as in the instance of the friends I was talking about, you know, they say go online and apply. You know, two things. You have to have an email account because a lot of the communication that they have with you is through an email account. So if you do not know how to use email, you need to learn that right quick. Because that is how they're going to communicate with you. You have to have an email account. And when you go online and register, you have to stop registering and go create an email account and come back because they require that. It is an online process. It's an online marketplace. But secondly, you know, when you are, most people are just living and working, and they're not looking at whether I'm eligible for Medicaid or not. They're just living and working. But the system is a system, like Dr. Randall was saying. So when you go online to healthcare, with healthcare.gov, and you go and you get ready to apply. As you're applying and you're looking at your pay information or your tax information, you're putting information in, the system has prompts already built in to notify you of certain eligibility. And your income, they know you're not at like 200% of the federal poverty level or whatever that little percentage is, 180, 200. If you are less than that, automatically it gives you a prompt. You are eligible to Medicaid. Now, every state is not doing expanded Medicaid the same way. Some states tried to opt out. They didn't want to do it. Other states said, well, we'll do it ourselves. Some states, the federal government's doing it for them. Different things are going on. So based on your state, in Ohio, we have expanded Medicaid through ohiobenefits.gov. Is that right, Joseph?
Correct.
So they'll say, hey, you need to stop your enrollment process on this federal website, and you need to go to ohiobenefits.gov and complete your registration there. And so now you have to go into another system, and you have to put your information in, because now you're eligible for Medicaid. But that's a mental thing. For some people, it's emotional to realize, what? I'm eligible for welfare? My income's that low? It's almost like an emotional blow for the system to tell you that your income is low enough that you qualify for Medicaid or expanded Medicaid. So it's not just a system thing. It's a very personal experience for a lot of people. And so if you've been laid off or if you have been underemployed, which is what a low-income job is, or unemployed, then you are more than likely going to qualify for Medicaid or expanded Medicaid. Expanded Medicaid is simply all those folks are eligible for Medicaid based on income, but not eligible based on the rules before. So if you were a man who was unemployed, and you didn't have kids that you were responsible for, you needed health care, but you couldn't go on the Medicaid and get on. Now, a man who's unemployed or unemployed can enroll in Medicaid because they've expanded the definition and more people are eligible. Kids who are in college, now they're eligible to stay on their parents' insurance until they're eligible at age 26. Not just college students, but any dependent or any young person up to age 26. I work with someone who is getting ready to get married, and she's on her parents' insurance, and she's going to stay on her parents' insurance even after she gets married, because it's her choice. You know, there are certain rules that apply now, and the rules have changed. So, you know, it's an opportunity for people to apply and not be ashamed because they qualify for Medicaid or expanded Medicaid, but look at it as an opportunity to have health care that was previously not available. Now, the next thing is, if you're eligible for the health care, you're eligible for the food stamps, you're eligible for a lot of other things that Medicaid offers. And so you get put into a system that you may not emotionally be ready to go into. It may take you a minute to absorb the fact that you actually qualify for food stamps, qualify for, you know, subsidized child care, qualify for, you know, these things. But once you, you know, go through the period of process and information, go ahead and apply and participate at whatever level it is that you wish to participate with. You know, maybe you might say, I don't want the food stamp. I just want the health care. You know, I guess that's your right.
Right.
You know, but at least don't just turn it down flat. At least participate if you can.
You said that they had to put their income in? The
system is tied to Homeland Security. It's tied to Social Security. It's all these things are already part of this system that you're plugging your information into. So it's going to verify all the information you put in anyway.
So they put in their present year's income, and then it'll right at the end what they qualify for. If they qualify for Medicaid, or if they qualify for the other insurance. Oh.
And actually, for instance, we did a health insurance enrollment on March 15th at Hero Heights Library. We had about 47 people that came, including some kids. We had 25 adults who actually enrolled and completed their application in that hour and a half that we were there. we were there about 3 hours, but an hour and a half after the after we did the talk on person, we did the runs. 25 people actually completed their application and were eligible, and the other 20 adults who were in there, they started the process, which meant they're in the system, but they needed a little more information. But you go all the way through to the end, and you put everything in that you have. At the end, it will say, okay, this is what you need to have. You need this, you need that, you need this, this, and this. So you can log out, and then you can log back on, because you have to have, they'll give you a username, your password, you have an email account, and you can continue the process later, but you can't start it and then finish it. And like Joe said earlier, if you're eligible for Medicaid, and they say you're eligible for Medicaid, at the end of your enrollment, there's a sheet that comes up, a page that comes up and says, okay, you complete your enrollment process. Now these are all the things you need to gather together. You're going to get a letter from your local Medicaid office, and then you'll have an appointment to go down and see them. And when you go, take this letter, and here's all the things you need to take with you. And so, they give you the information at the end, everything that you might need to take with you to an appointment. Very complete process.
Mr. Smith, you were talking about some of the positive aspects of the Affordable Health Care Act, and one of those, you were saying at one of the conference was that, for entrepreneurs, now they will have the chance to have health insurance. Can you talk a little bit about
Well, before, one of the big things with folks were, they say they're working at Company X, they said, man, I really want to go out and start my own business. I really want to do this. And they're like, I can't afford to do it because I'm going to lose my health coverage. So they're not willing to take the risk because, they'd be out there on their own. So, now with the Affordable Care Act, you'll have folks now that say, I really want to do this business. And now I can still have health coverage. And I'm lessening that risk. I'm going here to try to start a new business. You have folks such as the doctor, she's an entrepreneur. She's an individual. You got somebody saying, hey, I want to be an artist. I want to really go. I'll be able to afford health coverage and everything. So for entrepreneurs, it's really going to kind of open up an avenue where, and you even have people, let's look on the other end. You have folks that may have saved all their life and they're thinking about, hey, I could retire early, but they didn't have health coverage. Some folks say, I worked all my life, and I've saved money, and hey, I'm going to retire at, say, instead of 65, 60. And they say, oh, I can, go through the Affordable Care Act, and maybe I can still have coverage. That's the things that stop folks from maybe retiring early or doing other things in life, because that piece of the pie is so critical. Like I said earlier, what does health insurance really represent? Peace of mind. We don't want to use it all the time. And I kind of equate it to car insurance. You don't want to use it all the time, but heaven forbid you get an accident, what's the first thing you say? Thank goodness I've got insurance. I've got coverage. So, that's what it really boils down. But one of the things I did want to, on that website, the website for applying for Ohio Medicaid is www.benefits.ohio.gov. And that's the website there to actually apply for Ohio Medicaid. You can still contact a lot of local community centers, whether it's East End or Drew or over at the Wesley Center. Like I said, you can also go to the Ohio Department of Job and Family Services, like 4281. So there is some help out there. I know it's maybe a little bit complex, but get the folks that maybe can help guide you and get you the right information. Yeah, www.benefits.ohio.gov. She may have put it up there.
Yeah,
There you go. Okay. She's got the slide here.
So as I say, I do put in 2 months my regular job, when should I be applying for the health care?
And you're having a changing event, so you can apply, during that time frame, because because the open enrollment season is closed out for the Affordable Care Act. But if you have life-changing circumstances that occur, like say for example, you change career fields, or that open up to avail yourself to be able to change, be able to apply, because that's a life-changing event. They got several that they have listed. Okay. That may occur that enables you to go ahead.
I won't have to wait till
No, ma'am, because you're having a life-changing event.
Okay.
That's a different different circumstances.
But there is a time span
that you got to act on it.
that you have to act on, so you need to look because I don't know what it is, but it's like 30 or 60 days.
Yeah, it's rotated.
Within the life-changing event.
Right. So you can't wait, like, say your life-changing events, 1st July, you can't wait till like October, so, oh, I'm going to go ahead and do something.
Okay.
Because you'll be out there. But you want to check into that, and I can give you some information after the meeting.
I wanted to say, too, we talked about there being a penalty, but there is on the upside of that a subsidy. Some people that apply, when they do their enrollment, there will be a form whether or not they're eligible for a subsidy, and that subsidy system will pay for their premium.
It's a pretty significant subsidy this year, but one of this bring up a system issue. The amount of subsidy will vary based on the politics. And so that just because it's generous now doesn't mean it's going to be generous when a new administration, Democrat or Republican, comes in. And so I think that's one of the flaws is that people, I think that they subsidize it generously now because they really want to get people in the system, and I understand that. But how is it going to impact our community in the long term? Is that if they don't continue those high level of subsidies, that means that people will be spending more on insurance than they had originally planned for.
All right. And but did you have any questions? Okay. All right. All right. Well, we want to go ahead and begin to close out and just go down the line with any closing statements, and we'll start with the gentleman first.
Well, actually, I appreciate this opportunity to talk to the community. My name is Joseph Smith with CareSource. If you would like to plan to have your own forum, maybe at your church or maybe your community agency or something, and you would like me to come out and talk to you and have this type of forum, more than willing to do that. You can reach me. My direct number is 937-554-5076. And once again, I'll repeat that. That's 937-554-5076. That brings my phone. So like I said, if you have any type of community activity, health fairs, events, things of that nature, we're more than happy to be there to answer questions you may have. Like I said, thanks again, and again, happy Mother's Day to all the mothers out there.
Professor VERNELLIA Randall, thank you so much for having me, and everybody who's listening to this and participating. I think the point that I make, and I'll make again, is you can't fix a fundamentally flawed system by tinkering with it. Our community never fares well over the long run when that happens. And so while there is a lot of good things for individuals right now, the fact that we really didn't fix the system in terms of health care means that our community will continue to have access to health care problems, because ability to pay is only one part of the access issue. So we still have a lot of fight that needs to go on to get a different healthcare system.
I want to say I appreciate an opportunity to sit on the panel today to talk to the community about the Affordable Care Act. So today, whether or not you had insurance or you had the opportunity to be able to enroll with insurance, but that opportunity is certainly available now. I suggest that you take advantage of the opportunity. While it's available in the system, it is in place. It does provide access to care that was not available 6 months ago, a year ago. I do hope that you will take the time to become very well informed about the plans before you make a selection, because the plan you choose, it differs from plan to plan, and it's very important to choose a plan that works for your family. If you have a lot of sickness in your family, someone with diabetes, someone with a heart condition, someone with cancer, it's important for you to look at the plan and make sure that it's going to provide a level of care that you need for the situation with your individual family. It's not a cookie cutter type of what your neighbor got or what your friend got. Go in and look at it for yourself and get what works for you. If you have questions, do reach out to Joseph Smith or to any one of the individuals that were on the report before, so that you can get those questions asked. That's very important. And attend any information session that is available to you so you can ask your questions. And I appreciate those in the room who asked questions today. Those are very good questions. Thank you. And we hope that something was said today that helps some of our viewers better understand how affordable care impacts our community.
Thank you all. And we're going to go ahead and close out. There's an old saying that health is wealth. And for a long time, you know, our community has been poor. And one of the major contributing factors to our lack of wealth is our bad health. As you were saying, historically, we have had bad health, and that has been systematic and by design for the most part. So to close out, I would like to just give a few guidelines, and this is for preventative care, because an apple a day, they say, keeps the doctor away. And so if we don't want to use the Affordable Health Care Act, then we have to do necessary things that will keep our health in pristine condition. Some of the preventative guidelines is that if you have the desire, then you need to develop the will and gain the know-how to cast these demons out. Simply follow these 8 guidelines. Number 1, the first one is prayer. A lot of us, we may not know metaphysics, but they say that prayer is a non-thought, and that when you pray, you actually suspend aging through prayer. It says, you must let the author of all existence into your life. As I said earlier, it is prayer that feeds and strengthens our desire, and our desire feeds the will. Your will gives you the strength to cast out 7 devils and to begin to build yourself into a house fit for the habitation of God. Number 2, we must imbue yourself with knowledge. Knowledge is power. Number 3 is strive to eat, to live instead of eating inordinately or improperly in an attempt to deal with stress or to entertain ourselves. And there's a book by the Most Honorable Elijah Muhammad, How to Eat to Live, and there's a saying that we don't actually eat to live, some of us live to eat. Number four, we must exercise. What does exercise mean? Sometimes we think exercise means, well, I walked across, I parked all down there from the grocery store, and that's my exercise for the week. So no, you have to actually, exercise and break a sweat at least once a week. Number 5 is to get rid of your addictions. That is drugs and alcohol, smoking, extramarital sex. Many of us have problems just saying no. Number 6 is to get proper rest and relaxation. And this is in the news all the time, that Americans don't get enough rest. And it says, allow your body time to recuperate from the emotional stress and physical exertion of the day, to re-energize itself to meet the challenges of the next day. And last is that number 7, you should spend a little time in the sun and communicate with nature. And I remember that they just recently had National Park Day, I believe. They had these commercials where you saw families, and they were using mainly black families, and they were touching the trees, and just, nature is beautiful. And here in Dayton, Ohio, we have some beautiful parks that we can go to. And instead of, if you're wondering about the safety, then, this is a perfect place that we can take our children out to these parks and spend time with them and our family. And so with that, I would like to thank the panelists. Thank you all for this very informative forum. And I do hope that we are able to have some more forums like this to touch on the different aspects of the Affordable Health Care Act. I want to thank all of you who came out to view and those who are viewing via the webcast. And with that, I want to close out in the prayer of peace and prosperity. And may God continue to bless you and your family with the light of truth and understanding. Thank you all.
Thank you.
Can I make an announcement?
Yes, please make that announcement.
Some of you may not know, but Racial Justice Now is conducting a campaign to try to get the school board to stop suspending preschool to 3rd grade and to implement alternative discipline methods that we know work because they work in other places. I have information and petition here. If you could sign it, I would appreciate it. Just takes your signature and your zip code. You don't have to be a parent. You can be a student.
It's still on.
Okay. Also, we're having a conference. Dr. Umar Johnson is a nationally known expert on special education and African Americans, and he's going to talk about the role of special education and ADHD in the missing links to the school to prison pipeline. It's Saturday, May 31st from 1 to 6 p.m. at Central State University West Dayton campus. It's free. Please turn out. And thank you.
Thank you.
Oh. That's it. Thank you.
Thank you.
I